Hello, everybody. It's lovely to be with all of you. And today I'm going to talk to you about the COVID-19 pandemic and gender-based violence. We all know that domestic violence actually increased during the COVID-19 pandemic and various forms of gender-based violence. So I have been able to look at the literature and see what is available to us, and also talk a little bit about how to go forwards and be prepared for this issue in case there is another pandemic. In the next half an hour or so, I'm going to discuss some of the major issues, particularly in the context of low and middle income countries. Let me share my screen with you. Okay, so let's talk about domestic violence and the COVID-19 pandemic in low and middle income countries. So the relationship between the violence and viruses are not new. If you look at Ebola, HIV, Zika, and COVID-19, there are some similarities. Ebola in West Africa, there was an increase in sexual and gender-based violence, twice as many rapes, and a sharp increase in unwanted pregnancy rates. We all know that with HIV, women and girls were more vulnerable. Violence and fear of violence was a barrier to seek testing. In fact, in India, monogamous women had a much higher chances of developing HIV because, their partners had multiple sexual partners rather than the women themselves. And there's a strong link between gender-based violence and HIV the world over. With the Zika virus, it disproportionately impacted women and girls, and 73% of women who had Zika symptoms in the Dominican Republic actually did not seek help for fear of being assaulted. And of course, with COVID-19, we know that domestic violence reports doubled post-lockdown and helpline calls increased in many countries around the world. So these are some of the stories which I would like to share, which came to us in India. So this was 25-year-old Sunita, who was being stalked by her ex-boyfriend and was also sexually assaulted by him. She found herself pregnant, but was not sure of the paternity, but could not undergo an abortion as there was a lockdown and no medical termination of pregnancy services. And she presented to us in the postpartum with mood changes, psychotic symptoms, and poor bonding. So this is an example of violence manifesting as unwanted pregnancy, being sexually assaulted, and also not being able to access obstetric services. 19-year-old Meena, who has intellectual disability, her mother met her after 2 months due to lockdown and found bruises all over her body. She was found to be pregnant. Meena never complained to her mother that her husband and sister-in-law were abusing her, one, because of the intellectual disability, and second, because she thought her mother could not come and visit her because of the lockdown. Then we have 35-year-old Yasmin, a school teacher. She left home because of mental torture in her joint family because they were all staying together during COVID and everybody was working from home. Her parents would not let her into their house because of fear of COVID. Her husband would not let her use the mobile phone and constantly suspect her. And she was very, very distressed. But she said that, her mother doesn't want her. She wanted to leave her husband's home. But she was too scared to go to a women's shelter. What if she gets infected there, she told us. And then she had to go back to her the home of her husband where abuse continued. So I think these three stories give you the range of situations which can happen in a situation of lockdown or a pandemic, where access to services are poor, where there's a lot of fear, and when people are not really meeting each other. So what are the pathways and mechanisms of gender-based violence and COVID? One of the most important reasons why domestic violence increased was financial insecurity. In fact, it has been shown that at a time of economic insecurity, violence in the home actually increases. And this has happened even before the pandemic, but it got really enhanced around the pandemic. Then, of course, you have social isolation, and a lockdown with the abuser. So when women are isolated often and they don't have access to support services and the abuser is with them, there is a chance that the violence increases. One, because the abuser also knows that she may not be able to access support. The third is, of course, relationship conflict due to close proximity. So when there is already a very difficult relationship or a little bit of a fragile relationship, it tends to get enhanced. The conflict gets enhanced in close proximity. Another important issue is societal instability. So whenever there is instability due to war, due to disaster, due to either natural disaster or man-made disaster or a pandemic, governance structures start collapsing because everybody is focusing on health and crisis interventions, and that is a time where violence towards children and women actually increases. Women were unable to disclose violence because the perpetrators were always around them. They could not use the phone. They could not talk to people. Food insecurity and housing instability also added to the stress and increased violence levels. Alcohol, both the presence and absence of alcohol, and we'll talk about it a bit later, and then the fears related to the virus. So many women who were in helping professions like nurses or health workers, or community health workers, shelter workers, were often suspected to be carrying the virus, particularly in the first wave of the pandemic, where there was a lot of fear and stigma around it, and had to face violence. So this is a research roundup of violence against women and children during COVID-19, and this is data from till December 2020 from low and middle income countries. Studies focused on identifying trends, risk factors and dynamics, prevention program and impact analysis, and there were very few studies in the prevention program. There were various studies from Asia, Middle East, Sub-Saharan Africa, Latin America, and cross-regional, and I'm focusing on the low and middle-income country findings. So the studies focusing on identified these trends. 12 out of 15 studies showed exclusive increase in violence, 4 times increase in Jordan, and very, very high rates in China. 1 study from India had mixed finding, and 2 studies showed no change. But what is important to remember, that is no study which showed a decrease in domestic violence. Now, there's a huge challenge to the kind of methodological ways in which we could collect data for violence. So majority of the studies used survey methods, either online or via my mobile phone. So there were very few face-to-face studies because of the challenges of meeting women. A few studies which had some interesting methodologies. For example, in Jordan, it was a self-reported survey which was done in the health centers. In many countries, they use the Google search and Google mobility data. That is the number of searches and hits for partner violence, domestic violence, and these kind of terms. In China, it was by police service calls. In some other countries, it was through social media data, where women were seeking for help for domestic violence or internet search data. In Johannesburg, it was through hospital clinical assessments, and India, newspaper articles. So as you can imagine, it was very hard to do sort of first line level data collection for violence because of all the ethical issues involved, and because they did not want to compromise on women's safety. So the studies which focused on risk factors basically found that an increase in violence happened because of if a woman was married, if she was unemployed, either she was unemployed or the spouse was unemployed, where there was food insecurity, and of course, like even in non-COVID times, spousal substance use, particularly alcohol abuse. What were the factors which decreased the risk? These were high education level of either wife or husband. Now, this is again true for non-COVID areas. The times that domestic violence during non-COVID pandemic also decreases if with higher education, and women's employment. So if women were employed, the rates of violence were a little low. There was only 1 study which actually looked at an intervention, which was a youth empowerment program, and it found that it reduced multiple types of violence experienced by adolescent girls in Bolivia. And clearly this is an area which needs further research, and we probably will be seeing studies which have looked at various kinds of intervention during the pandemic, which is still not published yet. Violence during pregnancy also did not decrease during the COVID pandemic, and studies on pregnant women, for example, in Iran, they found that the prevalence of domestic violence was pretty high. nearly 35%, sexual violence 12%, physical violence 4.8%. And quality of life was significantly lower in the exposed group when compared to the unexposed group. In Ethiopia, there was a study done in a prenatal care clinic where also they found the intimate partner violence was around 7%. And out of these, emotional violence seemed to be the highest. Intimate partner violence was reported 1.52 times more often by women who reported that their partner consumed alcohol compared to women whose partner did not. So now that we've seen what is available in terms of data, there's been a lot of discussion around why gender-based violence increased with COVID. I mentioned some of the possible reasons. Like I said, poor coping, triggering conflict, arguments, and intimate partner violence. So when people were feeling very vulnerable, overall their ability to handle conflicts came down. Unemployment of men and intimate partner violence. This is called the male backlash. It has been described earlier that when men are unemployed, the intimate partner violence increase, particularly if the man is unemployed and the woman is unemployed. Female unemployment also increased intimate partner violence. Again, we know that studies report that women who are not employed face more partner violence. And in fact, the WHO's recent guidance called RESPECT advocates economic strengthening of women and men as a preventive strategy for IPV. Then, of course, with the social isolation and quarantines and all the mental health consequences of that. So we had seen even earlier that SARS and swine flu related isolation was associated with anxiety, depressive disorders, and suicidal ideation, and also impacted the mental health of men. Now, there have been several studies now which have shown that if men have poor mental health, there's higher perpetration of violence because their ability to manage their emotions decreases and aggression increases. Also, it has been seen that when men migrate to other places, the levels of violence decrease a little bit because they're not, there with their wives and families for too long, and then they come back for short periods during which things are not so bad. But however, during COVID, the migration decreased because people just went back to their families. There were no jobs. And so there was an increase in day-to-day exposure to the abuser. And finally, restriction of movements, food insecurity also led to violence. There was more coercive control. Now, there's a slight difference between coercive control and violence. Coercive control involves monitoring of, telephone calls, basically controlling everything that the woman does, who she talks to, who she communicates with, what she wears, how she speaks. So when men were more at home, they tended to, use more coercive controlling methods. The isolation was not just geographical, it was also functional and social. And there was a lot of surveillance and regulation of activities. Like I mentioned in one of the examples, that the partner would keep checking mobile phone messages and suspect if there was a message from what looked like a male friend. We also know that any disaster-related societal instability, like high rates have been associated with intimate partner violence, like earthquakes, infectious disease pandemics, mentioned earlier, loss of usual governance structures, and separation from families. So many adolescent girls, because of sudden lockdowns, were away from their parental families, had to stay in relatives' homes or friends' homes, again became very vulnerable. And in places like India and China and some other countries where there were closure of borders, so young girls could not go back to safe spaces and were very vulnerable. The other important thing that happened was there was a lack of access to first responders for violence. So healthcare settings were not open. Many women use the healthcare service as a way of talking about violence. So because healthcare settings were shut and they were focusing more on COVID, women did not have access to their doctors, to their nurses, to their health workers. Women themselves were reluctant to visit health facilities due to fear of infections, and increased burden on health services led to collateral damage. So many places where women would talk about partner violence, like mental health services or obstetric services, because of the increased pressure, there was collateral damage, and there were not enough health workers. In the initial first wave, shelters and counseling centers were not recognized as essential services. So some of them were not open. And in cases of sexual assault, in many situations, there was poor access to emergency contraception, post-exposure prophylaxis, and medical terminations, like we saw in our first example. I also mentioned the role of alcohol. So there was increased drinking, but sometimes when there was sudden lockdown, there was a decrease inability to have access to alcohol, both of which actually led to intimate partner violence. We know that the presence of alcohol, especially acute alcoholic intoxication and heavy alcohol consumption, are the most robust correlates of IPV perpetration. There becomes an increased concern about personal power, a disproportionate reaction to perceived insult and threat to masculinity or identity, and what is called alcoholic myopia, that is an inability to look at the context or situational factors. So even if somebody says something small or there's a perceived insult, there's heightened reaction due to alcohol. So many people started drinking excessively because they were at home, there was nothing else to do, and that also increased the levels of violence. An interesting thing that happened in many countries like Malawi, India, and Bangladesh were an increase in child marriages. So, the number of child marriages increased, again, due to several reasons. One is governance structures came down. Second, in places like Malawi, communities desired, like I mentioned, to protect the girl children because they felt that they might be more vulnerable. So they felt that getting them married was an easy way out. And because there was no child protection in many of these places active especially during the first wave and early second wave, child marriages happened even though they were illegal because young girls were not going to school. So usually when adolescent girls go to school, they tell their teacher that, their parents are thinking of getting them married. But then there was no access to any of these. And that too led to increase in child marriages. And many helplines, child helplines, particularly in India, girls called up in distress because they feared that they were going to be married against their consent. There was violence towards health workers, women health workers particularly, because we know that a large number of nurses and community health workers are women in many countries. So they were at the receiving end of violence because the fears and stigma. Many women were not allowed to enter their homes, and women who were infected, particularly in obstetric settings, had to face a lot of obstetric violence. Now, one of the challenges with data on gender-based violence during a pandemic is that there still is limited rigorous data available on how epidemics have changed levels of violence. And most of it is from secondary data through organizations or perceptions. There are ethical challenges in obtaining prevalence and incidence data on GBV during pandemics, as is the case in other humanitarian settings. And because vulnerable groups may not seek testing, support, or care because of distrust of surveillance of healthcare services, and many women, particularly with disabilities, adolescent girls, older women, women with mental illness, refugee migrant women may not actually access many services or may not be approached even by research agencies. So there is hence a sort of lopsided kind of data that we might get in these situations, and we should always be aware when we are reporting rates or risk factors that these very special groups may not have been covered. And there's also not enough data on the pathways by which these pandemics can exacerbate different forms of violence against women, including how different drivers of violence change during an outbreak. So the UN Women and WHO sent out a guidance as early as April 2020 because they knew that there's going to be a lot of research. They said, try and use secondary data because the safety of respondents was priority. So even if you wanted to do door-to-door surveys or phone surveys, you have to be very careful, including WhatsApp surveys or online surveys, that partners were around, and if children were facing abuse, then parents were around. So it would be very important to ensure that there was safety. So They basically recommended secondary data, key informant studies, trying to do data collection in health settings where women might have more privacy, data to focus on new onset of violence, exacerbation of violence, and relationship to alcohol and child abuse. Also to look at protective factors and any existing platforms that existed for online and phone service, rather than creating new platforms, to sort of add a line saying, do you feel safe, rather than adding, asking specific questions about violence. We all know that, there was poor documentations in helpline and shelters. So even though, one of the studies that we tried to do, we found that there was very poor documentation, and somehow the focus seemed to be only on physical violence, though we know that psychological violence and sexual violence is equally important. Some of the global responses had been increase in helplines all over the world. There was a lot of aggregation of resources by WHO, by the World Psychiatric Association, by the UN, by other women's organizations. And there were several government responses, including some interesting methods. One was something called Mascarilla 19, which is basically you could actually go to a chemist and say Mask 19, and they would know that there's violence happening and would connect you to services. So chemists and pharmacists were the only places that women could go during those periods all by themselves. In India, there was a WhatsApp chatbot called Shakti Aunty. Shakti means courage, empowerment, which basically had, this kind of a chatbot. Hi, I'm Shakti Aunty. I'm here to help you understand and enforce your legal rights. How can I help you? And so women could actually access a chatbot just for getting knowledge and finding out whom they could reach out to through WhatsApp. In Malawi, when they realized that internet was not going to be very feasible, they started help girls getting Bluetooth technology on their mobile phones. And in Russia, some of the hotels were converted into shelters for women. So these were some of the global responses, particularly a great number of increase in various ways in which women could access help, sensitizing the police, sensitizing the counselors in telecounseling, which a lot of counselors were not really used to. So remote ways of helping women. But there were huge challenges. We looked at, women, counselors who were in shelters, and they said that they found it very hard to reach women because transport was not available. Women could not reach them. And in fact, they suggested that if we could have mobile methods of shelters, like have vans or something which go to different villages, so that women can access counseling at their doorstep rather than having to reach a shelter through transport, which was not always available during a pandemic and lockdown. So I think we need to remember that we need to prepare for the next crisis. We need to declare shelters and one-stop centers as essential services. We need more safe houses, and also need guidance on COVID-19 precautions in these shelters. So a lot of women were very scared of coming to shelters because they thought there were other people with COVID-19, there would be crowding. The shelters themselves, or the one-stop centers, did not really know what to do and developed COVID protocols, because there would be vulnerable women and children in these places, and they would all be staying together. We need to use more remote methods and better use of technology. I think one of the things that came up in the COVID-19 pandemic was the gender gap in mobile phone ownership. So if we are wanting to access everybody through mobile phones, then it's very important that we close the gender gap, and much cheaper and better internet access. I think governments need to find ways in which we can reach those who have the least resources, and much cheaper internet methods, cheaper phones, smartphones, I think are very important to reach people, and people to reach us. Like I mentioned, mobile methods of service delivery, accessible legal facilities. So one of the things that courts did in India was they started doing online trials and online ways of court procedures. However, you needed to have an internet for that. Digital safety and reporting mechanism. So one of the things that came up, because all of us were on Zoom and young children were on Zoom, young girls were on Zoom, there was a lot of cyber violence as well. including sexual violence. And so it would be very important to ensure the more we depend on digital methods to ensure digital safety, integration of prevention messaging into all COVID-19 healthcare work providers material. So one of the things that we found was that while there was a lot of focus on health in the protocols, the gender-based violence issues are not addressed as much as they should. And of course, community gatekeepers and bystander education. In a time when governance systems cannot be there, it's very important for neighborhood vigils, for people to be very aware of what they can do as community gatekeepers to help if a woman is facing or a child is facing violence. So we need to also prepare for the specific needs of adolescents, women with disabilities, and marginalized women, particularly refugee women. Strong alcohol-related policies about the quantity of alcohol in situations like this that should be accessible. We also realize that the mental health of men is very important, particularly in situations of non-employment. And as a result, I think it's very important that economic policies like stimulus packages, which can help improve the family's well-being, but also improve decrease domestic violence and family-related interventions, strong involvement of women as key stakeholders. So one of the things that we found was that in many task forces across the world, there were not enough women representatives or representatives from marginalized groups. It was predominantly men, predominantly people from sort of, higher education, higher resource, people who are making all the decisions. So it's very important if we are looking at gender-based violence to have enough women from, from various stakeholder groups to be involved in these task force policy and making bodies. And we also need to remember that mental health intervention should be part of GBV services. One of the things that is found is that people who are working in mental health do not have adequate knowledge of how to handle gender-based violence. People who are working in the gender-based violence field do not have adequate training in managing mental health situations, including self-harm. So this is something that needs to be done, and that the governments need to integrate gender and gender-based violence in all their policies. Now, this was the sort of, the visible COVID map at the end of, 2020, where there were lots of areas. You see the dark blue areas where COVID hit very badly. And this is the domestic violence map. And if you can see many of the areas in the world where domestic violence was high, like, 43% in South Asia, in Sub-Saharan Africa, the COVID map was also quite high. So it was sort of correlating with each other. So while there was a visible pandemic, there was also an invisible pandemic. These are some of the resources, particularly which were available for the area of perinatal mental health in the area of COVID-19 and gender-based violence. And thank you very much for listening. So thank you very much. I'm sure you have questions, please direct them to me, and I'll be happy to respond to them by email, or if I'm available after the session, maybe on chat. Thank you very much.
All right, the next video, also by Dr. Prabha Chandra, is titled, What Healthcare Workers Should Know About Intimate Partner Violence.
Hello, everybody. We just talked about COVID and domestic violence, and I think it's very important for us to understand what health professionals, and particularly mental health professionals, counselors, anybody providing psychological support for women facing specifically domestic violence need to know. So in the next 25 minutes or so, I'm going to discuss a little bit about this topic. Let me share my screen. So what should health professionals know about mental health in women facing violence? I have no conflict of interest. How does intimate partner violence relate to other similar terms? So I think it's important for us to understand terminology, because many things are, words are used. So spouse abuse, wife abuse, or wife battering is specifically related to the partner and the wife. Domestic or family violence relates to violence by anybody in the family. It doesn't have to be the partner. It could be any family member. Violence against women or gender-based violence is a much more broader term, and it's based on gender. So it includes sexual assault or any other form of sexual harassment. Interpersonal violence is violence between any two people. Dating violence, again, may involve any gender, and it's usually related to dating and younger people. And of course, we have sexual assault or sexual violence, which is not restricted to the intimate partner. I think it's very important for us to understand what psychological violence is and what the concept of coercive control or controlling behavior is. I'm saying this because a lot of studies have found that psychological violence is underreported by women, because they don't understand or don't recognize it as emotional violence. And for example, in the National Family Health Survey, which was done in India, rates of physical violence and sexual violence were high, but rates of psychological violence were very low, as reported by women, which seems a bit counterintuitive. So psychological violence includes recurring criticism, verbal aggression, jealous behavior and accusation of infidelity, threats of violence and threats to end the relationship, destroying property, and hostile withdrawal of affection. Controlling behavior or coercive control, which is also a form of emotional violence, but it is more controlling in nature, is isolation from family, friends, support networks, giving limited access to money and finances, surveillance of everyday tasks like grocery shopping, like why have you bought so much, and is it necessary, you're spending too much, intercepting mails, calls, texts without consent, threats to children, pets, or other cherished possessions, and monitoring of computer and phone use. So all of these come under the gamut of psychological violence and controlling behaviors. And what has been shown by the WHO multi-country study on violence, they have found that psychological violence has as much impact on mental health as does physical or sexual violence. So it can't be under recognized, or its importance cannot be diminished. Now, we heard earlier about the COVID pandemic and violence, but we know that the prevalence of violence against women is pretty high. 1 in 3 women throughout the world will experience physical and/or sexual violence by a partner, or a sexual violence by a non-partner. And if you look at the different regions, while the rates seem to be highest in the Southeast Asian region, they're not really less in other regions of the world as well. So I think it's important to recognize that violence happens in low-income countries, in middle-income countries, in high-income countries, in people within the countries, in all strata of society. So what is the mental health impact? Now, the mental health impact could be, the commonly held sort of impact of post-traumatic stress disorder and complex post-traumatic stress disorder. And I'll talk about that a little later. Depression, anxiety, sexual problems, sleep and eating disorders, suicide, self-harm, chronic pain, worsening of psychosis, and somatization. And you've heard, in this conference, the fairly high rates of suicide and self-harm among women, particularly in South Asian countries, which seems to be clearly linked to social factors, particularly domestic violence, and may also lead to risky behaviors such as substance use and risky sexual behavior. Another thing that we must recognize that there is a high prevalence and odds of domestic violence and abuse and sexual abuse among people with severe mental illness. So while it's true that mental health, the mental health of women who face violence is not optimal, we must also recognize that people with severe mental illness also face disproportionately high rates of domestic violence. So if you look at this study done by Louise Howard from the University College London in the UK, what they found was that if you look at the rates of domestic violence, since the age of 16, and the darker orange is women with severe mental illness, and these are controls. This is men with severe mental illness, and these are controls. You can see that the rates of domestic violence are almost double, more than double in women with mental illness. Similarly for sexual assault. And while even among men the rates are high, the rates among women are disproportionately high. A systematic review of psychiatric patients and intimate partner violence, where 42 studies of inpatient and outpatient psychiatric patients were reviewed. Approximately 30% of women inpatients and outpatients had a lifetime history of IPV. It's often unrecognized by health professionals, which is very important. And the odds ratios of depressive disorders, anxiety disorders, and PTSD were much higher in women with a mental health problem who were facing IPV compared to women without a mental health problem. We would think that intimate partner violence is not common during pregnancy, but a systematic review of intimate partner violence during pregnancy and perinatal mental disorders in low and lower middle income countries found that the rates of physical, sexual and psychological IPV were pretty high during the perinatal period, which includes the pregnancy and the postpartum period, with suicidal ideation being a major problem. And pregnancy IPV increased the odds of antenatal and postnatal depression. Another important aspect that we must remember that partner violence, independent of anxiety and depression, can actually lead to low birth weight and preterm deliveries as well. So violence during pregnancy could have fatal outcomes and non-fatal outcomes. Fatal outcomes include homicide and suicide, and non-fatal outcomes, which include negative health behavior during pregnancy, reproductive health problems, like I mentioned earlier, including miscarriages and unsafe abortion, and of course, mental health problems, including difficulties or lack of attachment to the child, and have an impact on child mental health as well, and infant mental health. In fact, our studies have shown that conflict in the family and violence in the family can impact babies even as young as 6 months old. So all perinatal mental disorders associated with domestic violence, there's an increased odds of depression post-IPV. And what has been found that IPV also increases following depression. So in some ways it appears that the depression incident IPV, which basically means that if a woman is depressed, chances are that she's going to face violence seem to be higher. And that probably is because she's not able to protect herself, and she is more vulnerable to violence. Another condition which is very common in many countries, particularly South Asian countries, African countries, where depression can manifest differently, is somatization disorder. And we need to remember that women who face violence may often not talk openly about depression, but will have a lot of somatic complaints, particularly those who are facing physical violence. So pain is the most commonly reported symptom, and areas of reported pain can include chest, arms, legs, joints, back, abdominal pain, and other areas. We found women who are being hit on the head many times report headaches, movement disorders, weakness, dizziness, and fainting. And if there's associated anxiety, then many times there is digestive symptoms such as pain, IBS-like symptoms as well. there may be a constant worry about potential illness, and there's a feeling that medical evaluation and treatment have not been adequate. And this is because probably many times when women come with somatic complaints, we don't ask about partner violence. And so there's a feeling that it's not been understood adequately, and there's frequent and repeated checking body for abnormalities. Now, let's look at the commonest condition, which is post-traumatic stress disorder. But in many countries, it's not recognized adequately. For example, people in India feel that, they don't have post-traumatic stress disorder in India. And our studies have actually shown that PTSD is present, as well as subthreshold PTSD. Now, we all know that PTSD is a lasting consequence of traumatic events that cause intense fear, helplessness, or horror. And we know that women who face partner violence can face very severe fear and helplessness. And if it happens in a chronic manner, then the impact is even more. Complex PTSD is a condition where women or people are facing repeated traumatic events such as violence, neglect, or abuse, or it's more chronic. Particularly if women have faced sexual abuse in childhood, bullying, and subsequently are facing partner violence. And it's often a combination of the PTSD symptoms associated with specific symptoms such as poor self-concept, inability to trust people, dissociation, and emotional dysregulation. So the commonest symptoms that you will ask for in women who are facing violence include night terrors, nightmares, fearfulness, flashbacks, and many times if you use the term flashbacks, women may not understand, so you have to sort of explain it to them that, sometimes you feel as if the violence is still happening, your body is reacting, disturbed sleep, avoidance of situations and triggers related to violence, like I mentioned, negative beliefs about oneself, particularly if it's complex PTSD, a sense of hypervigilance, lack of trust, and this often manifests as lack of trust with the health professional as well, because they feel that maybe, health professionals cannot really help them or will not keep things confidential, and mood swings as well as emotional dysregulation. So when do you refer? When do health professionals refer someone, a counselor refers someone to a mental health professional? When should it be done? To whom should you be referring, and how should it be done? So if you see a woman who's facing violence and there's risk of self-harm or suicide, if she's so depressed that she cannot do any day-to-day activities, if there's severe flashbacks, nightmares, anxiety, or other symptoms of PTSD, when psychological distress persists despite counseling. So while not all women will need specialist psychiatric care and can be supported through counseling, if the distress persists, and of course, if there's psychosis or severe mental illness. How to refer? I think it's very important for health professionals not to simply write a referral note or just send the woman, because many times she may not really be able to navigate her way through health systems because she already is feeling very powerless and fragile. So setting up an appointment, calling the mental health professional and briefing them about the case, making a referral letter, follow up after the referral with the health professional, as well as giving feedback to the survivor about what is being planned. I think more and more there's sort of concerns and attention to the mental health of perpetrators, because one thing is to help the woman manage her emotions, but it's also important to remember that many perpetrators may have mental health problems. They may have been exposed to partner violence or abuse as a child. Several families, society believes, particularly patriarchal families, may condone IPV. They may have anger management problems, or may sometimes have a personality disorder. Alcohol, particularly excessive use of alcohol, has been clearly linked to partner violence, and that is something which may need attention. The person may be depressed or may have other mental disorders, mental health problems like psychosis, ADHD, as which causes impulsivity, and more families are coming forward with partner violence, particularly in older women, where the partner may have dementia or other organic brain syndrome. So is suspicious, is irritable, and occasionally physically violent. So what are the barriers to domestic violence abuse disclosure by mental health service users? So when women this is not just true of mental health service users, any service user. We have found that there are very, many barriers why women do not talk to health professionals about domestic violence. And I just want to go over this a little bit because it's extremely important for us if we want to help our women to know what prevents them from talking to us. So one is, of course, the hidden nature of domestic violence. And like I mentioned, not realizing that this is abuse. Many times professional failure to respond to signs of abuse. So even if there's obvious abuse, you don't kind of respond to it because you think it's not a health issue and it's a social issue. Cultural factors, dominance of the medical diagnostic and treatment model and not looking at women's, social realities and cultural realities. Women may have shame and embarrassment. They may be blaming themselves. They may fear social service involvement, and particularly if a woman is just in the migration process or is waiting for a citizenship or something like that, she may fear that there may be consequences of that. There may be fear that disclosure will result in further violence, and this is something that a lot of women worry about. That it's possible that the health professional will call the partner and say something, or the partner may suspect. So, and of course, that the fear disclosure will not be believed, that they will not be trusted. So all of these things are important for us to recognize why women don't tell us, and we must find ways of facilitating disclosure and seeking support. What are the barriers to inquiry by mental health professionals and also by other health professionals? One, I think the key thing is about lack of knowledge and expertise about domestic violence. And that is why talks like this are very important for health professionals to, orient themselves about domestic violence. Many times we may think of things like, she should leave the man, or why is she with the person? Did she do something to provoke the man? So these are the kind of myths that we as health professionals hold. So there's lack of confidence in approaching the subject. We feel it's too complex an issue. We think it's a personal problem or our own discomfort with the topic. And this might be because if the health professional herself or himself is either perpetrating or is experiencing IPV, they may feel very apprehensive about it. Domestic violence may not be a priority. There may be limited opportunity for inquiry. So there may be presence of partner, time constraints, competing demands, or crowded outpatients, lack of privacy. Again, dominance of the medical diagnostic and treatment model, a lot of focus on symptoms rather than what is behind the symptoms. When there's no obvious indication of violence, gender, culture, fear of re-traumatization. This is a very real fear that a lot of health professionals have, and fear of offending. That if you ask somebody who's looking who's like maybe a doctor or a teacher or something like that, and you ask them, they might feel offended. So they don't sort of routinely inquire and check about some of these things, but which are very, very important. So we did this study during the time of COVID because we knew domestic violence was a big issue, and we asked psychiatric residents how often they identify IPV in their care, and we asked 125 trainees and senior registrars about IPV, and they said that spontaneous disclosure was only in 68%. Occasionally, and very often only in 16%, and 15% of women did not even talk about this. 63% said that they occasionally ask about IPV as routine care, and most of them said that many of them said that they don't ask. But what was good was that at least a third said that they do ask. Confidence in assessing for various forms of violence, and this is very interesting, that they were more confident in asking about physical violence than asking about emotional violence. And I think as much as women are not able to talk about emotional violence, we are not able to ask about emotional violence because we don't know what constitutes emotional violence. And asking about sexual violence, residents were very less confident. We asked residents whether they ask for IPV in specific situations. And of course, if the woman had bruises, they were asking, but and of if there was self-harm, or if partner had alcohol dependence. But somatic symptoms, which are a very common manifestation of IPV in women, only a third of them said that they asked. What were the barriers? The main barrier was lack of training and supervision. There were a lot of concerns about victim safety. And one of the things that we are trying to do is to create posters, which we put in women's toilets or in the office of the psychiatrist or the nurse, where if a woman is coming there, she can see it there and then talk about it. Say, this is a safe space to talk about domestic violence. It will be treated like, with privacy and confidentiality. The psychiatrist may have a lack of knowledge about available resources. And this seems to be a big problem, that if we open the Pandora's box, then what are we going to do for them? And concerns about medical legal issues. And finally, a sense of therapeutic nihilism that, nothing will happen. This is part of society. It's a societal problem. And, women have to bear with it. I can't do anything about it, so I will not ask about it. So for those of you who would like to, have some resources, I think this is a wonderful resource from the UK, and it's called the LARA VP, which actually has, and it's, I will give you the website address later, which actually has a lot of details about how do you ask these questions about mental health as well as about domestic violence. And I think one of the things that we need to do before we ask somebody is asking ourselves, am I ready to ask? Is it safe to ask? Do I know what to do if I receive a disclosure? Do I feel adequately trained? And do I know how to refer my service user for further support? I think all of these things we need to know. And very often, sometimes, we think that we can't ask. Asking even a single question means that people with experiencing domestic violence can know that you're willing to listen, so they're not on their own. Find out that you understand that DVA affects mental health, discuss with you how to improve their safety, and find out about sources of help. So one of the things that we often recommend is that you can ask by asking an open question, so that your concerns that you may be offending them is not there. And saying something like, I know that 1 in 4 women experience abuse from someone close to them. So I ask everyone if this has ever happened to them. Has anyone close to you ever hurt or frightened you? And then ask a little bit more about, what happens when there's an argument? Does somebody belittle you? Does somebody hurt you? And have you been feeling any, feeling that you're being, monitored and put down, and then sort of then build up towards physical violence and sexual violence, taking consent and checking their mental health at each point. So one of the issues that we have been, focusing on internationally is what could be an ideal IPV identification tool. We know that in some countries, screening is recommended, but majority of the studies have shown that just screening is not a good idea. You need to focus more on clinical assessment and make sure that there are pathways in which you can support them if IPV is revealed. But to do that, you need a good identification tool. So there is no one best tool right now. There are several tools which are available, but each of them has their own problems. So something that can be used internationally should be psychometrically robust. Of course, it should be reliable, valid, and feasible to use in real world setting, which means it shouldn't be too long, too complex. And it should incorporate perspectives of people with lived experience of IPV. And I think that's very important. It should be able to identify at minimum the 3 common types of IPV, that physical, sexual, and psychological abuse, able to identify the sex and gender identity of the person committing and the person experiencing IPV. It should incorporate assessment of frequency, severity, and duration of abuse. So some of them just say, have you been facing abuse or not? Yes, no. In the last 1 month or in the last 1 year. So I think it's important to check how severe it is. Have you ever needed hospitalization? Have you had a mental health issue? Have you thought of self-harm? How often does it happen? It should be easy to use across a variety of clinical and non-clinical settings. It should be easy to integrate into any mental health outcome and risk assessment. It should be suitable for use with all genders. It should be culturally sensitive. Several tools have been translated into Arabic and Hindi and Tamil and Spanish, and some of them have found that not all terms can be used, and some are a little offensive in some cultures, particularly related to sexual violence. And most importantly, it should be adaptable for use in low literacy context. So we need to figure out if you can have computer-assisted methods of rating oneself, rather than everything being done by a rater, an interviewer asking, and women may feel more apprehensive. So something which is, which keeps in mind low literacy levels as well. And we right now don't have this, a tool which has all these qualities. So how health providers can support women who have experienced violence? We use the WHO Lives approach. L is for listen closely with empathy and no judgment. I is inquire about their needs and concerns. V is validate their experience, show you believe and understand. E is enhance their safety. And S is support them to connect with additional services. I think if you use the Lives approach, it kind of encompasses what a woman really wants. I think the key thing is to remember to do no harm, to keep the woman in control, to make sure she has autonomy and respect her wishes rather than thrust your ideas on her. When IPV is disclosed, you can use words like validation, like unfortunately, this is common in our society. Affirmation, violence is unacceptable. You deserve to feel safe at home. Support, there are things we can discuss that can help. Ask about safety and plan as needed. No critical remarks like, why don't you just leave? Respect her decisions and concerns. Know about local legislation and other services and refer appropriately, like I mentioned, and document carefully. Documentation is very important if you subsequently want, if there are divorce proceedings or other legal issues. I think documentation is extremely important, including injury charts, etc. And documenting about mental health and self-harm, which we seldom do. What are the therapeutic interventions? It's, most of the interventions, like I mentioned, are individualized, focusing on safety and stability, providing social support, stress management skills for emotional regulation, some specific psychological methods like trauma-focused cognitive behavior therapy, eye movement desensitization, and reprocessing if there's PTSD, and this has to be done by specialists, treating mental health and physical health comorbidities, recognizing difficulties with stress, not pushing her to leave, and recognizing stages of change. And I think very important to remember that couple therapy is not always safe, and always be very careful before you start doing couple work in situations of violence, because there can be escalation. Talk to a peer before you think of doing couple therapy. These are several studies which have been done, and what they have found, these systematic reviews, that with using a range of psychological therapies which have been delivered by a variety of staff like social workers, nurses, community health workers, family doctors, that you can actually decrease depression and anxiety. Definitely more evidence for depression than anxiety. And even in low and middle income countries, using community health workers, studies have actually shown that you can reduce depression and anxiety. So if I want to become somebody who wants to encourage the evaluation and intervention for domestic violence in my team, what do I do? I think the important thing is to explore whole team training from local DV agencies. And one of the important things is to not just to focus on health professionals, but also include reception, management, administrative staff. And that's something that we are doing now with support from the Ministry of Women and Child Development in our country, that we are training all one-stop center staff, including the security staff, including the clerical staff, including the person who greets the person first, because I think trauma-focused care and trauma-informed care should start right from the time the woman enters the door, rather than only by a health professional. Ensure that the staff knows how to contact your local domestic violence agency and establish a relationship. Display information posters in waiting rooms and patient toilets. Provide clinicians with cards detailing local DVA services. And every service probably needs a domestic violence lead. So for example, in my center, we have a team of us who focus on women's mental health and domestic violence, and people approach us. leaders and managers should embed and promote safeguarding and empowering staff. Many healthcare staff themselves experience domestic violence, and I think team leaders should foster an open culture to try and see both survivorship and perpetration and how to create policies for staff. So I think this is very important rather than only focusing on the individual health professional, to develop an environment which focuses on gender sensitive care and also provides services like this. So these are the transformation of health services to respond to violence against women and girls. This is a book on domestic violence and mental health, which is very useful. It's by the Royal College of Psychiatrists, and I have found it extremely useful for myself and for training. These are some. I'm just sort of summarize some of the things that we need to do in transforming health services. I also want to focus a little bit on unconscious biases that we have, and how to respond, and how the training should happen in every specialty, in the undergraduate, postgraduate, and in the continuing professional development. We can't stop, and having more peer support, having trauma-informed approaches, as well as reflective practice, and caring for mental health professionals who themselves have experienced IPV. As part of research, I think routine IPV data collection and reporting is important. If you're doing a longitudinal cohort study, including IPV in that, whatever the mental health study, if you're doing it on self-harm, suicide, or on depression, children, I think it's important to include IPV, and also to investigate the moderating effects of IPV on treatment. So you might be using treatment methods or doing RCTs in women, and you should look at how IPV moderates some of the effects of those treatments. This is like a training program going on where we are using the World Psychiatric Association Intimate Partner Violence curriculum. For those of you who are interested, you can go to the website of the World Psychiatric Association, which has educational resources and the educational portal, and that has a very good curriculum with reading material, videos, case studies, self-reflective exercises. And we do that regularly for our trainees, and this is one of the sessions going on with both male and female trainees, and trying to use more interactive methods of training, and also focusing a lot on attitudes. These are some of the useful resources which I mentioned at the World Psychiatric Association, which has recently been revised in December 2020, and I urge those of you who are interested. It's a free resource, so please, look at it. You might find it interesting. Some other resources include the NIHR resource, which is an Oxford Health resource, which has a lot of details on mental health networks, on violence, abuse, and mental health, many videos for self-training. These are some of the WHO resources, and then there is a McMaster's Canadian resource, which Professor Helen Herman, myself, Donna Stewart, many of us, Harriet Macmillan, have contributed to, and this is also a very nice resources with some exercises to be done. So I think I'm going to end here, and I hope you were able to get a little bit about why it is important to look at mental health among women who face violence, why it is important for women who seek help for mental health, for us as health professionals to ask about domestic violence. How do you ask for domestic violence? What are the barriers by women who present to us? What are our own barriers and that we need to change? And if a woman tells us about violence, what do we need to do? Thanks for listening. This is my Twitter account. This is my email. And this was a kite which was stuck in front of my office room. I work in a place with a beautiful garden. And I thought that this was the plight of a woman who is in a violent situation. She wants to fly, but she's stuck between the branches. And it's our job to release this kite and allow this woman to fly. Thank you very much, and I look forward to any queries that you might have, and you could email me and contact me for any of the resources that I have mentioned before. Thanks a lot.